Welcome, everyone. Good evening. Thank you so much for taking the time to be here with us this evening. My name is Dr. Daniel Anaya. I'm the chair of the Department of Gastrointestinal Surgical Oncology at Moffitt. I'm a senior member. I've been with Moffitt for 10 years, and I practice doing surgery for gastrointestinal cancers. I'm very excited to introduce you to my colleagues in just a moment. And I'm really confident that you'll find value in the information we'll share with you tonight. It so happens that March is the Colon Cancer Awareness Month, and we are going to be focusing today in colorectal cancer, so very timely. But before we begin, please be advised the content here is not intended to be medical advice, and the viewers should consult their physician should they have any questions. The viewers should not rely on information contained in this presentation or webinar for immediate or urgent medical needs. Additionally, if you think you may have a medical emergency, call your physician and go to the nearest emergency department, or simply call 911 immediately. Never disregard professional medical advice or delay seeking care because of information contained in this presentation or webinar. Okay, with that said, and again, we're very pleased to have you here with us tonight. And I want to remind you all that you will have the opportunity to have questions answered by these experts. So I invite you to just basically type your questions in the Q&A box, which is located in the bottom part of your screen. But let me start with introducing Dr. Amalia Stefanou. Dr. Stefanou is an associate member in the Department of Gastrointestinal Surgical Oncology. She's a fellowship-trained colorectal cancer surgeon. She has broad experience in surgical care for colon cancer, rectal cancer, and anal cancers. And she treats these cancers by doing surgery, which includes procedures that are endoscopic, open traditional surgical treatments, as well as minimal invasive surgical approaches, including laparoscopy and robotic surgery. Her research interests focus on surgical quality, especially how to measure, define, and optimize care for surgical patients. So welcome, Dr. Stefanou, and please take it away.
Thank you, Dr. Anaya, and thank you all for joining the call tonight. I know we're all really excited to share some information about what we do at Moffitt. So the goal of my talk is to give you some background on colorectal cancer and why we should care about it, why we should be talking about it. And so it's a very common cancer. As you can see, there's a lot of people that are diagnosed every day around the country, and I'm sure all of us know somebody that's been impacted by this disease. So it's very common, but it's the second most common cause of cancer death, which is another really important reason to talk about it. When you look at this slide from the American Cancer Society, you can see that the incidences of new diagnoses, starting from 1940 on the left side of the screen down to 2020. So the numbers are heading down. But a big time period of when they started to go down is around 1980, which is when colonoscopy started to become an important test that we recommend for screening. And so most colon cancers come from colon polyps. And so that's why it's important to think about colonoscopy. So around that time is when people were starting to get colonoscopies. And that means that colon cancer, when caught early, can be very treatable. Next slide. So when you're thinking about when a patient is diagnosed and they come to Moffitt, what are they thinking? How are they feeling? And so when I see new patients with new diagnoses, pretty much they're feeling overwhelmed and afraid, and they have a lot of questions. So I'm going to hopefully use my time tonight to talk about what we can do to help people through this journey. They want to know why it's taking so long. Is that going to make a big difference for their overall care? What treatment options are there? Can they have surgery? Are they strong enough to have surgery? And really importantly, will they need an ostomy? This graph here shows you that we have increasing numbers of patients coming to our institution every year with colon and rectal cancer. So even though across the country, new diagnoses might be heading down, here at Moffitt, we're taking care of more and more patients with colon and rectal cancer. Next slide. When colon cancer is caught early, over 75–80% of patients are very treatable and can even be cured. And when we see a new diagnosis of colon cancer that is not metastatic, that means not spread to the liver, to the lungs, surgery is really the standard of care. And like Dr. Anaya mentioned, we have the tools to do robotic surgery or laparoscopic surgery, which means small incisions, in addition to open surgery, which is a larger traditional midline incision. And patients who can have surgery tend to do really well with 7 to 90% overall 5-year survival. So that means they're still alive, doing well 5 years after their cancer treatment. So to help overcome some of that, here at Moffitt, my colleagues and I, which is four colorectal surgeons and 3 advanced practice providers, are able to see patients with new diagnoses of colon cancer within 7 days, so that if a new patient calls, they're feeling anxious, understandably, we're able to accommodate new patients quickly into our clinics for a complete evaluation. Next slide, please. This is a short slide just to highlight robotic surgery. So up in the right upper screen, you can see kind of a little diagram of the operating room, but the other picture's covering it a little bit. And then the middle screen shows you how we do the operations. So depending on where the cancer is that we're targeting in our operation, we can place these ports into the abdomen and then put air inside the abdomen to lift the abdominal wall off of the organs. And then we use a special camera and instruments. It gives us wristed mobility in the operating room to do the operations, a 3D magnified view, and it allows us to do very complex surgery through very small incisions and then take the specimen out through an also very small incision. Patients who are able to have robotic surgery do very well. They have shorter hospital stays, lower rates of wound infections or blood loss, and cancer outcomes are at least as good as open surgery. And so we're able to provide this very important service here at Moffitt. Next slide, please. Next, I'm going to talk about some specific populations that I think are important to consider in colorectal cancer. So this group is early onset. These are patients under age 50. The definition's a little fuzzy, but we tend to put all patients under 50 into this category. And the graphs on the bottom show you all ages with colorectal cancer. So again, you can see the incidence is kind of trending downward, but for patients under 50, you can see it's the reverse. The graphs are heading up. So that means more patients are being diagnosed. Younger patients tend to wait longer to seek care or might not be referred quickly by their primary care doctors because young patients, we don't think they usually get cancer. They also have unique considerations. They might have small children. They're still in the workforce. But once they're diagnosed, they really desire timely, comprehensive care. And this is important for all of young onset GI cancers. The graph on the right shows you the age distribution of patients that we see at Moffitt. And you can see also that we're seeing patients in their 20s and 30s and, of course, in their 40s with colon and rectal cancer. Next slide, please. The other end of the spectrum are geriatric patients. So in the general population across the US, about 17% of people are over age 65, and that's expected to go up. Here at Moffitt, we operate on patients over 65. About 30% of our patients are over 65. So this is a very important group for us as well. And these patients also have unique concerns. They're often have other medical problems and a lot of different medications. And so it's really important for us to make sure that we're doing the right operation at the right time and really helping patients make important decisions about their healthcare and their goals going forward. We're also working towards a geriatric surgery verification through the American College of Surgeons, meeting the 6 standards you see at the bottom of the slide. And our plans are to have a site visit for this verification towards the end of this year. Next slide, please. The last 2 slides that I have talk about rectal cancer in particular. So thinking about colorectal cancer, the colon is the majority of the large bowel and the rectum is the end of the large intestine. And rectal cancer is evaluated in a different way from colon cancer and can be treated in a very different way depending on the stage. And in general, when colorectal surgeons are looking at their practice, about 20% of patients they take care of have rectal cancer. Here at Moffitt, about 37% of our patients have rectal cancer that we take care of. So you can see the graph at the top shows you the breakdown of all the cases that we've seen in the past 10 years of patients with rectal cancer versus colon cancer. Patients with rectal cancer have truly multidisciplinary care, and that means that they see me from surgery, they'll see one of the medical oncologists and one of the radiation oncologists, because all of these modalities are very important to treat rectal cancer. And we choose the treatment sequence really dependent on where the tumor is in the rectum and what it looks like, so what the local stage is. So you can imagine that coordination of this care is vital to having the best outcomes for patients. And when we looked at a sample of our rectal cancer patients, we found that about 40% were receiving some of their care here at Moffitt and portions of the chemotherapy or the radiation at other facilities. And that is concerning because it can be tricky for patients to navigate two centers, doing some care one place, knowing when to come back for follow-up. And we're worried that that could affect treatment and clinical outcomes overall. Next slide. In the past, we would do a different sequence of treatment for rectal cancer. So patients would get radiation, then surgery, then chemotherapy. But now really the bulk of all the radiation and chemotherapy is given up front. And that's been shown to have better compliance. So that means patients can receive all of their treatment and tend to do better overall. The other outcome that we found with giving treatment this way is that about 20 to 30% of patients will have a complete clinical response. And that means that their tumors go away based on endoscopy, so a short colonoscopy, and MRI. The pictures here you see on the right is where you can see at the top would be a complete clinical response, so the tumor's gone. All the way at the bottom would be the tumor still there. Patients who achieve a complete clinical response are able to follow close surveillance protocols. That means they see us frequently for scopes and imaging, but it allows them to not need surgery, right? They're allowed to preserve or keep their rectum. And so this outcome is a really important endpoint for patients, and being able to coordinate their care allows more patients to get to this outcome. Next slide, please. So in the future, our goal is really to improve ease of access. So make it easier for patients to get to us so that they can have options when looking at their treatment for colorectal cancer, especially the early onset groups and our geriatric patients. In terms of rectal cancer, future directions is we're hoping to enhance our program with a coordinator to help these patients with coordination. And we're looking towards accreditation for the geriatric surgery program as well as our rectal cancer program. Thank you.
Thank you so much. That was a really outstanding talk, Dr. Stefanou. I'm sure we're already kind of seeing a few questions coming up. I love how you really emphasized, the fact that when we diagnose these patients with early on during their cancer journey, through prevention strategies like colonoscopy, you can actually provide treatments that are intended to cure the patients, like surgery. And I'm so proud of our colorectal group. We provide all types of existing cares for our patients, all types of surgeries. But not only do we do that, but they are really leading the field in a lot of the things that we do, like this watch and wait approach, in which patients actually are spared of having a big surgery or ending up with an ostomy. And a lot of these things are coming up from our own group at Moffitt, and it's being taken on by other people and other practices. So very, very proud of them, and looking forward to answer some of the questions that are coming up. And so thank you, Dr. Stefanou. Now we'll pass it on to our next speaker, Dr. Tiago Biachi. He's a medical oncologist at the Department of Gastrointestinal Medical Oncology at Moffitt Cancer Center, and he's an associate professor also at the University of South Florida. He's primarily focused on treating patients with colorectal cancer and liver cancer, but he's also a clinical investigator, and his research is primarily focused on clinical trials and biomarkers, drug development, and new targeted therapies for patients with these tumors. So very excited to hear you talk. Take it away, Dr. Biachi.
Thank you so much for a kind introduction, Dr. Anaya. Really happy to be here, especially during this March Awareness Month for colorectal cancer. As Dr. Stefanou mentioned, unfortunately, we still have many patients affected for this disease, and it's really important to deliver what I mentioned here, like the right treatment for the right patient. And I want to start with this, and actually, this is we're seeing this transition in medicine, but and also in oncology and colorectal cancer. So we're moving from let's say traditional model using chemotherapy, surgery, and radiation for all tumors the same way, to a more, I would say, tailored method to treat those patients, mainly those patients with more advanced disease. So in the past, we used to use, for example, the same chemotherapy regimens for all patients with colorectal cancer. And now we know that, for example, we have several different types of colorectal cancer, mainly, again, for patients with advanced disease. We might have different options available for those patients, including target therapies, with monoclonal antibodies, sometimes with, TKIs. Those are, special oral drugs that we can use for, to treat colorectal cancer. Of course, most of this information is coming from very comprehensive, genetic analysis that now we are able to do in those tumors. So nowadays, we can use, it could be a tissue-based genetic test. So we can do a biopsy, a regular biopsy, and send this to the lab to do this very comprehensive genetic sequencing of this tumor, or sometimes even, a blood test to detect different molecular alterations in the circulation. So we call this, circulating tumor DNA. So all of those methods are, able to guide us, how we're gonna, deliver the best treatment for the, for each patient. And of course, immunotherapy as another, resource that we're seeing. Unfortunately, I would say, for advanced disease, this is a type of treatment that is still available for a few, I would say, a small number of patients with advanced disease, but we're moving toward a scenario that we might be able to use this, in patients with localized disease, as I'm going to mention in a couple of minutes. Next slide, please. And this is just to to give a kind of idea how this works. So we can imagine every cancer cell as like a bubble, and each of these bubbles actually has millions of proteins in the cell surface, so millions of receptors. And we can say that those receptors, for example, can trigger many processes inside the cancer cell, including process like multiplication, evasion, etc., but also can be recognized by our immune system. So we have this is quite interesting, but for example, nowadays we know that tumors on the right side, for example, can be really different, regarding molecular profile compared to tumors on the left side. And for many years, of course, we used to treat all the patients at the same with the same drugs. But for example, nowadays, patients with more advanced disease, we might select different types of chemotherapy or different types of target therapies based on the tumor location. So just because the tumor was started on the right side, it can be a totally different tumor because of the molecular analysis compared to a tumor on the left side. Essentially, when we say, the regular immunotherapy using those drugs that we have available, or, commercial available, like pembrolizumab, nivolumab, essentially what we're doing with those drugs is releasing those brakes. So we have those receptors in the cancer cell. Those receptors are responsible for inhibition of our defense cells. As you can see there, those T cells are our immune cells. When we use those drugs as nivolumab or pembrolizumab, we're essentially releasing those cancer cells to attack the cancer cell. Unfortunately, those drugs work for again a very small number of patients, and one of our researchers here actually is essentially trying to identify those patients and trying to increase the number of patients who might be eligible for this technology. Another approach will be using different types of immunotherapy, including TIL therapy, as we'll hear more today from Dr. Pilon-Thomas. You can pass to the next slide. talk a little bit about this immunotherapy with immune checkpoint inhibitors, as we call those approved drugs. Essentially, again, what we're doing is for those tumors that we call mismatch repair deficient or tumors with MSI high, those tumors are infiltrated, as you can see on the lab. They are infiltrated with many, immune cells surrounding those cancer cells. So when we use those drugs and release those breaks, the immune cell and you can see as a T cell can definitely attack the tumor cell. So that's why those tumors are essentially very sensitive to immunotherapy. On the other hand, a tumor without this genetic alteration is usually a cold tumor. So that tumor doesn't have a lot of immune cells in the microenvironment. So if we just release the break of a T cell, we might not have enough T cells surrounding the cancer cell to see a real effect. Usually we'll see we'll have this discussion with patients with metastatic disease, but this is changing right now, and we can move to the next slide because more recently, we figured out that, for example, patients with localized disease might benefit from immunotherapy too. So this study was published a few years ago from the Italian group, and actually what they did was very few cycles of immunotherapy. So actually 2 cycles of immunotherapy, two infusions with 2 drugs. And they noticed that almost 80% of those patients had something they would call pathologic complete response, which means that those patients received those 2 infusions and then they had surgery. And when they sent this pathology to the lab, the pathologist couldn't see any tumor, any residual tumor in that, that sample. So we might be talking about a disease, or at least for part of those patients, because we'll see this only in those patients, again, with that genetic alteration that I just mentioned. But for patients with localized disease, we might see this in about 20, almost 30% of those patients. So we might be able in the future to treat patients with localized disease with this genetic alteration, even without surgery. So, of course, that will be something that will need like more trials, to validate this kind of, approach. And those trials actually are undergoing right now. Next slide, please. Speaking about trials, and of course, this is one of my passions, and one of those things that we're doing here at Moffitt. And actually, developing and approving a drug, it takes a village. So it takes time. So we know that in median number is about 10 years for since they started drug development to get this drug approved. It takes money, so median number is about 2.6 billion, and the reason why it takes so much money and so much time is essentially because this new drug has to go through all these phases. So initially we have a lot of work that we call preclinical. So this is still done in the lab. And then we have phase 1 trials, and we do have a solid, phase 1 department here at Moffitt. So those are trials using, new drugs for the first time in patients. And usually those trials, test this new drug in about, till 100 patients, I'll say. So dozens of patients or sometimes a few hundreds of patients. And then we're going to move forward to a phase 2 and a phase 3 trial. So we do have several, phase 2 and phase 3 trials at Moffitt, testing, new drugs in those patients with colorectal cancer. But unfortunately, we know that only about 10% of those trials, able to pass through the phase 1 trial will end up being, 10% of those drugs will end up being approved, down the road, because of course, most of those drugs will fail in the phase 2 and the phase 3. So, and of course, this is only possible because we have sometimes to complete a phase 3 trial, we have, thousands of volunteers. So thousands of patients were enrolled in those trials. Of course, part of those patients might have received a drug that will be approved, after, many years. So it's a very exciting process. It's challenging because we're talking about, several new targets. So it's sometimes really hard to, really identify a potential, target that can be used in patients with, with colorectal cancer. And I think that's what I have here, but open to questions at the end.
Great. Thank you, Dr. Biachi. That was an outstanding talk. I think it really emphasizes that, colorectal cancer treatment has evolved drastically over the last couple of decades. And even in just the last few years, I think the last 5 years, there's been significant developments into actually using our immune system by giving medications that really kind of enhance that immune system to kill the tumors. The other thing that I think is worthwhile emphasizing is while, in surgery and in medical oncology and other types of specialties, we deliver really the top-notch care. Being at a place like Moffitt, as many of you may know, being an NCI comprehensive cancer center, not only you get that top quality care, but you also have the opportunity to really be part of how the cancer treatment is developed. Like here, not only we are developing ways in which we deliver care, thinking about the patient needs and the type of surgeries that are needed, but also in which the trials that we open and the trials that we use to enroll patients to really advance the field are trials that really kind of mark the way things are managed in the future. And of course, this requires a lot of effort, a lot of support, but that's why we're here, and it's a big part of why we're here and what we want to do as part of our mission. So thank you again for that talk. And next, I would like to pass it on. This is a great segue to Dr. Shari Pilon-Thomas, who's going to talk a little bit more about the immune therapy and the immune development for colon cancer. Dr. Shari Pilon-Thomas is a senior member of the Immunology department here at Moffitt Cancer Center. Her research focuses on the advancement of immunotherapy as a really powerful tool against cancer, including vaccines and adoptive T-cell therapy. She'll explain a little bit what that is. She received her PhD in immunology from Wayne State University and completed her postdoctoral fellowship in the Department of Surgery at the University of Michigan. She's currently the scientific director here at Moffitt of the TIL Development Lab and co-director of the Center for Immunization and Infection Research in Cancer. Dr. Pilon-Thomas' research program is one of the leading efforts to really bridge what we call basic science, all the experiments that we do in the lab, to clinical immunotherapy trials that actually can be implemented in patients with solid tumors here at Moffitt. So welcome, Dr. Pilon-Thomas. Thank you for being here and take it away.
Thank you, Dr. Anaya. So quickly, I'm going to give you an Immunology 101 lesson. It'll be really easy. Dr. Biachi already introduced T cells a little bit in his talk, so I'm going to expand on that. So next slide, please. So when we talk about the immune system, the cells of the immune system, these are your white blood cells. And one specific cell that I'm going to focus on today is the T cell. And the T cell is the effector cell of the immune system. It's actually the cell that does stuff. After it's educated in the lymph node, so when you get a cold and you feel like your glands are swelling up, it's actually your T cells are proliferating in your lymph nodes and getting ready to fight an infection. So after being educated, these T cells will travel out of the lymph node and into the different tissues or the site of infection. So T cells are very important for maintaining inflammation and getting rid of bacterial infections and viral infections. They will actually kill virally infected cells. And I always say most people know a lot more about T cells than they think they do because depletion of T cells by HIV leads to AIDS. And the genetic loss of all T cells is called the bubble boy syndrome. And you see this in some children that are born without T cells. Next slide, please. So the way an immune response works against tumors or against, an infectious agent is that tumors are taken up by these educator cells. And these cells are cells such as dendritic cells or B cells, which we're not going to talk about today. And then these educator cells will take pieces of the tumor and present those pieces on the surface of their molecules. And if a T cell can recognize that piece of tumor or piece of bacteria, piece of virus, the T cell will become activated. Then it will travel back, and what we hope is it will travel back into a tumor. So next slide. And my job at Moffitt Cancer Center is to find T cells in solid tumors, including colorectal tumors and other tumors, other gastrointestinal tumors. And I can tell you I can find T cells in every single patient's tumor for the most part. So you might ask, well, if every patient has T cells in their tumor that recognizes their tumor, why do they have a tumor? tumors only become tumors if they find strategies to evade the immune system. They can shut off T cells and other immune cells in the tumor microenvironment so that that T cell, although it's in the tumor and it could recognize and kill the tumor, it's shut off. So there's various cells, and you don't need to memorize these, but there's other regulatory type cells, regulatory T cells, there's suppressor cells, and then there's those molecules that Dr. Biachi was talking about. Tumor cells will express markers on the surface that can directly inactivate those T cells that are in there. So next slide. So one thing that we can do is we can take the T cells out of tumors, take them in the laboratory, and reinvigorate them. So these T cells that actually infiltrate tumors are referred to as tumor infiltrating lymphocytes, or TIL. And we know, like I said, that the TIL are exhausted and dysfunctional in tumors. But the presence of TIL in tumors in general leads to an overall better prognosis for patients, because that means that they did have an immune response in their tumor at some point. Eventually it did get shut off, but it does correlate with a better response. And we know if we can take these TIL out of the patient's tumor in the laboratory, we can reinvigorate them and expand them to high numbers and give them back to the patient as a personalized therapy. And that's what we call adaptive cell therapy with TIL. Next slide, please. So on the left, you kind of see the wheel of TIL. Basically, a patient with a solid tumor has a surgery and the tumor is removed and brought to the laboratory. And what we do there is we chop that tumor up into small pieces or fragments. And then each fragment is plated in media containing T cell growth factors. So what happens is each piece of the tumor is able to give rise to a whole pool of T cells. And there will be T cells in the tumor that recognize the tumor, but there'll also be other T cells in there that happen to be passing through the tumor at the time of surgery. So what we need to be able to do is figure out if those T cells that we grew actually respond to the patient's tumor. So what we do is we take the pool of T cells that we grew, the pool of TIL, and we co-culture it with the patient's tumor. We put them together and we look to see which pools of T cells can kill the patient's tumor. And then we can pick out the pools of T cells that are actually functional against our patient's tumor. And then we can expand those numbers. So we might start with 1 million T cells, but at the end we end up with 10 billion T cells. And then we give this back to the patient as a therapy. So the patient is treated with some chemotherapy, which wipes out their white blood cells temporarily so that there's space for these T cells to come in and survive and proliferate and get to the tumor site. And so this is the strategy of adaptive cell therapy with TIL. And it's really been pioneered in metastatic melanoma. So these are patients with stage 4 metastatic melanoma that have failed standard of care therapies. And overall, we see a 30 to 50% response rate. And this response rate is durable. At the Moffitt Cancer Center, patients that have responses within the first year of their TIL therapy remain tumor-free for a decade after that treatment. So they're basically cured of their tumor. FDA approved TIL therapy for metastatic melanoma 1 year ago in February of 2024. So next slide. So our goal now really is to try to expand TIL therapy to other tumor types, especially colorectal cancer. I just wanted to show some of the responses that we saw in our metastatic melanoma patients at Moffitt. I don't have a mouse, but this is a CT scan, and this is a patient's, basically their shin, where they have a tumor growing on their shin. And you can see from the CT scans by 1.5 months after treatment, the tumor has shrank, and by 12 months it's gone. And the patient was able to come off pain medications at 1.5 months, 1.5 months after getting his TIL therapy. Next slide. So this is another CT scan. This time it's of the patient's lower jaw. So on the left side of his face, he has this very, very large metastatic melanoma lesion. And by 11 months, the lesion's completely gone. So, the power of these T cells to get rid of very large tumors is evident here. Next slide. So what are we doing about TIL for GI cancer? So we've really started a big program in GI cancer. So I've been really fortunate to work with the surgeons in the gastrointestinal department. They get tumors, resect tumors from their patients that come to the laboratory. And as you can see on the right, 66% of those tumors were able to expand TIL. On the left, you don't need to know this, but those TIL produce interferon gamma, which is a marker that these TILs are actually effective against the patient's tumor. And then we're able to take a small number of those TIL and expand them up to high numbers. So we basically have the data in place to move forward with a clinical trial for patients with colorectal cancer, but other GI cancers. So we're very excited about our program, and we're looking forward to hopefully getting this into our patients. So thank you.
Thank you so much, Dr. Pilon-Thomas. This is, she does such an amazing job in simplifying such a complex process. But it's also such a novel and exciting process. 10, 20 years ago, we were so far away from actually using our own body and our own cells to actually kill a tumor completely, tumors that were completely lethal, like melanoma in the past. And the fact that we are doing it right in our doors, in our labs, and actually testing on our own patients is really fulfilling. And we're very excited to see where this takes us. So thank you so much. At this time, I want to take a moment to introduce one of our partners here at Moffitt, Mr. Tyler Wilson. Tyler is here really on behalf of David Curry. David Curry could not be here tonight. Some of you may have met David. David is wonderful. He's with the Moffitt Foundation, and he really partners with us in the GI program to ensure that we receive the research dollars that we need to get clinical research off the ground and really make advancements in cancer treatment. So if you'd like to know more about how you can help or how you can connect with us, please contact any of us or David to find out about more. Tyler, I don't know if you want to say a few words.
Sure. Thank you, Dr. Anaya. Really honored to be here. I know David has been a phenomenal partner for the entire GI program in his long tenure at Moffitt. I'm really grateful to fill in for him while he has another donor engagement, and just to hear some of the remarkable advances that are happening across colorectal cancer research and treatment. It's truly been remarkable, and thanks so much to those who are watching tonight, as well as those that currently support these initiatives. I think across the board, you can see the impact of philanthropy at each one of these levels, and the opportunity to really utilize philanthropy at every stage of research as well as treatment, whether we're advancing in in-house clinical trial at Moffitt or working on translational research being led by Dr. Pilon-Thomas. It's truly remarkable to see where the research and treatment are headed, and I think philanthropy plays such a huge role in those types of opportunities. As Dr. Anaya mentioned, if you have an interest in making a gift, you can reach out to David. His contact information is listed there. You can also designate a gift to colorectal cancer research or the GI program simply by noting on the memo line of the check or through the online portal that you'd like to have the gift go towards GI research or colorectal cancer research. So we try to make it as simple as possible to support these initiatives, but certainly if you have any other questions, feel free to reach out to David and he'd be more than happy to help direct your initiatives going forward so that they have a meaningful impact for any one of these initiatives shared tonight. And I'll turn it back over to Dr. Anaya for the Q&A.
Thank you, Tyler. We really appreciate all the philanthropy that's for really making our research possible and the benefit of our patients. Now I would like to invite everyone to ask any questions that you may have to our speakers tonight. You can write the questions in the Q&A box, which is kind of in the lower part of your screen, and I'll be happy to read and direct the questions to our invited faculty so that we can discuss them. While you log in and ask and write your questions, I'm going to start with a few here. Does after cancer treatment, mean 5 years after chemo ended or 5 years after diagnosis date? So I guess it's a question about kind of surveillance, and I think there is a similar question that asks if there is basically, let me get to this, does the rate of reoccurrence of adenocarcinoma go down after being cancer-free for 3 years post-chemo treatment and surgery? So maybe Dr. Stefanou, do you want to take that question? How do we do surveillance, and does recurrence change over time, and when do we consider success, and what are the measures that we normally use?
Those are really good questions, and of course, risk of recurrence always depends a little bit on the stage of the original cancer and the patient's ability to receive all of the treatment that was recommended. But most surveillance begins after treatment is complete. So that's where the survival numbers are coming from, is after treatment's complete, not diagnosis. And then most surveillance programs are for 5 years, because we think that after 5 years, if a patient hasn't had a recurrence, their risk goes back towards average risk. So 3 years with no recurrence, I think, would be very promising for a person. An individual should feel good about that. But again, it's a little hard to be able to make a blanket statement. But surveillance programs last 5 years because we think most recurrences, if they're going to happen in the first few years. And we just want to make sure we're watching people closely after their cancer treatment.
Great, thank you so much. We have another interesting question here that maybe Dr. Biachi or Dr. Pilon-Thomas can tackle. And this is a patient that is attending this webinar, 39-year-old with Lynch syndrome, who had colon cancer and was treated at Moffitt successfully with surgery and chemotherapy back in 2022. And all his follow-up, thankfully, has been completely clear. And he's interested in participating in clinical trials that use cancer prevention vaccines. And some of those are being used that he refers to Mayo Clinic or Arizona. And he just wants to kind of get your opinion. Maybe Dr. Biachi can take this, or anyone else, about cancer vaccines for this specific population. We're so glad that you are cancer-free and that everything has kind of worked your way, but also a very relevant question because you want to prevent any potential future cancers. Dr. Biachi, you want to take this one?
It's a very interesting point, and actually, vaccinating cancer is a really hot topic now. We have many trials ongoing, not only for colorectal cancer but for many other GI tumors as well. So we do have, for example, one trial for pancreas cancer, gastric cancer here at Moffitt. So he mentioned about this trial open at Mayo, and I think it is something really interesting to discuss, because maybe those patients with Lynch syndrome, what happens with with those patients essentially is those tumors are usually very hot. So those tumors are they display that genetic alteration that I mentioned, like the mismatch repair deficiency. So usually this is a tumor that is really hot for the immune system to and it's easy for the immune system to recognize those cancer cells. So this kind of vaccine should be something interesting in this population. Of course, we don't have results from those trials, so those trials are still ongoing. So we'll need to follow those patients for a couple of years to see the real effect. But for example, there was a study published last year, maybe 2 years ago, that showed that, for example, those patients who had received immunotherapy, to patients with Lynch syndrome who received immunotherapy to treat one cancer, they had a lower risk of developing another cancer in the future. So probably because we were able to trigger this immune system, and that's why that patient those patients probably develop less cancers down the road. So I would say probably this Lynch syndrome should be one of those most, I would say, promising population for a vaccine approach.
Great. Dr. Pilon-Thomas, I know you of course, this is right up your alley, and you also happen to be part of the leadership at the immune therapy and vaccine kind of center that we have at Moffitt. Do you have any comments on this?
Yeah, so I don't know that we actually have an active trial open, but we are working on a dendritic cell-based vaccine for patients, after they've been treated for their cancer, in that post therapy, but nothing yet. Check back.
Got it. For the prevention. Okay, another question. I think this one maybe for Dr. Biachi or Dr. Stefanou. Do you recommend a special diet after chemotherapy and surgery for stage 4 colon cancer patients?
I can comment on that. And, there's a lot of discussion about, diet. And of course, we know that this, has a real impact in colorectal cancer. We know that the reason why we're seeing, more young patients probably with colorectal cancer now is probably because, lifestyle, and lack of exercise, but also because, the diet that we have like in the West, poor in vegetables and, rich in red meat and processed food. And I used to say, I prefer to say to tell my patients to stay healthy, after, treatment is completed. So there's no, one specific diet that they have to follow. But for example, we have this data that patients with overweight or obese patients, they have a higher risk of recurrence compared to patients with normal weight after they completed the treatment. And we have this data for colorectal cancer, and we have this data for breast cancer. So probably because, the fat in our body can, produce some hormones, and those hormones might, be able to, feed cancer cells. So I would say that the right diet is a diet, rich in vegetables, poor in, red meat and processed food. And I wouldn't say only diet. So, the key here is, keeping, for example, a healthy lifestyle, including a healthy weight.
Right. Dr. Stefanou, maybe you want to chime in regards to diet and colorectal surgery specifically.
Yeah, just I agree with everything Dr. Biachi said, and patients ask me this all the time. They all come to clinic and say, should I give up sugar, or what can I do? And I think the most important thing is to take a high component of your diet being plants, whole foods, decrease the processed foods. Those are really good. And we all know what the right things are to eat, right? We all know what's healthy, what we want to feed our kids, but that's going to help your body support it through surgery and recovery and chemotherapy. So I think, common sense, a diet high in fruits and vegetables, lean fats, and being a healthy weight and not smoking, I think are the most important things patients can do to support themselves.
Right. And we have a really interesting question here. Is there any hope that with AI, we would expedite the development of cancer-related drugs and vaccination? Who wants to take that one? We happen to have, I think we're one of the few cancer centers in the nation that have a machine learning department that really focuses on using AI as well as all the tools of that sort to help us develop new drugs, but also to help us develop ways in which we can predict responses to therapy and things like that.
I can take that.
Go ahead, Dr. Biachi.
I can take that. So yeah, it's a very timely question. So actually, we're having a meeting with the company next week, and we're planning to establish a partnership with our AI department here. And I think this is really promising. If we think about how the drug development works, and I said that we have a long path, even before bringing this molecule to the clinic. So this works happens in the lab, and usually, in the past, we used to use like mouse models. So we had to, implant a tumor in the mouse and then treat the mouse, with the drug. Of course, this takes time, takes a lot of space, right? And then they are kind of transitioning to something that we call PDOs, which is essentially micro tumors that we can, develop in the lab, like in a plate. And now there are a few companies developing some chips. And those chips are they are able to kind of reproduce the tumor, in very small piece, and we can test a bunch of drugs at the same time with a very short, turnaround time. And that's where, AI can help, because we can analyze what kind of response we're going to have with a bunch of drugs in a short period of time. And then we can, better select which are those drugs that are promising to take to the clinic and, test in patients, starting in the phase 1, phase 2, and then phase 3 trials.
Right. Very timely and novel question, and something that we are really investing in Moffitt and really want to pursue as part of our research portfolio. Okay, here's another question. I'll pass this one to Dr. Pilon-Thomas. Is immunotherapy the same as TIL?
So TIL is a type of immunotherapy. So any therapy that acts to boost the immune system is considered an immunotherapy. So TIL is just one type of immunotherapy that, the blocking antibodies like nivolumab or I don't know, Keytruda, and I don't know what their official names are types of immunotherapy also. So.
Right. And a follow-up to that, is there an active trial for using TIL for colorectal cancer patients?
There's not one open right now at Moffitt. Hopefully, Dr. Anaya and I are going to get one going soon. But right now, there's not one at Moffitt.
But we're working very hard with the whole teams, colorectal, medical oncology, and our research partners to go there. Okay, let me jump into a shorter question while I read a longer one. Thank you for your presentation. Are there any trials targeting the KRAS mutations at Moffitt? Tiago, you want to take that one?
Many. So we used to, call those patients with KRAS mutation, but nowadays we know that we have different types of KRAS mutation. Probably the most promising one is called KRAS G12D, and this is about 20, almost 30% of patients with colorectal cancer. And we do have at least, 3 active trials at Moffitt now, maybe a 4th one coming Q2 this year with KRAS inhibitors. So for many years, we knew that, for example, KRAS was a mutation that causes, resistance to a class of drug that we use for colorectal cancer. But now we started, having drugs focused on this KRAS, and this is very effective, at least in colorectal, pancreas, and lung cancer. And we do have a couple of trials open right now and recruiting patients for those tumors.
Great. Okay, this question appears pretty good for Dr. Stefanou. This is a patient of ours who very appreciative with the care provided at Moffitt, who has rectosigmoid cancer stage 2. He did his course of chemo, she did her course of chemo, and is currently conflicted on whether to proceed with surgery or with radiation. And while the chemo responded well, she wants to know if with radiation there's risk of killing good cells as well, and if the cancer can regrow in the scar tissue.
That's a really good question to consider without giving medical advice in a webinar like this. I think that's a very important question that when we're faced with this situation here at Moffitt, we discuss our patients at a tumor board, a multidisciplinary tumor board, like we talked about previously, where we have the radiation oncologists and the radiologists and the surgeons and the medical oncologists, because there is a lot of new information about rectal cancer, so that not everybody's treated the same. Some patients should absolutely get radiation. Some patients may not need radiation because of what we've learned about rectal cancer and the specifics of where exactly the tumor is in the rectum. So I can't answer your question specifically other than to say there is evidence saying that patients may not need radiation for specific locations, but patients who omit the radiation should definitely have surgery if they're able to have surgery, right? If they're medically fit for surgery. So this is a big question, and I would encourage anybody in the situation where they have an upper rectal cancer, which may not need radiation, to talk about this and consider it with their surgeon, with their radiation oncologist. I'll say that the radiation that our radiation oncologists can give to patients is very targeted and minimizes damage to normal healthy tissue, but it's still radiation that has some risks. So definitely something to consider and talk about with your physicians.
Right. And this is kind of a question similar to a previous one. Do you see AI helping colorectal treatment or diagnosis? I think we talked a little bit about that. Or will it help AI TIL in any way? Dr. Pilon-Thomas, do you know of any combination of how we can incorporate AI into the development of TIL?
Yeah, so it's something that we're very interested in doing. We're starting a collaboration with our AI department at Moffitt, where we can start taking characteristics of tumors, how many T cells are in those tumors, and then seeing if we can correlate that with TIL growth and TIL activation, and so.
Yeah, this is great. Very engaged audience, and I think you're all hitting really on the key, very educated audience. You're hitting on all the key topics that are really novel to the field of colorectal cancer and cancer as in general. And you know, it's music to our ears because it's a lot of the things that we are doing at Moffitt. We love these interactions. Okay. Next question. I was told I can't get surgery because I have metastasis of the colorectal cancer. I have been fighting cancer since 2011. Dr. Biachi, you want to take that one? Do we do surgery or do we have some?
Yeah, I mean, I prefer to say to my patients that, treating a patient with metastatic disease, this works like a chess game, right? So we're going to plan a remove, and then we're going to, repeat scans and, check the opponent, which is the cancer in this case. But it all depends on where, this patient, has metastases, the amount of metastases, because sometimes, and this is the main difference when we're talking about colorectal cancer compared to other tumors, we can cure patients with metastases, right? So, and if we can, for example, if we have a patient with liver metastasis, then we can do local therapy for that liver metastasis, including surgery or radiation or ablation. We can cure, part of those patients. Of course, a patient with, disease is spread in many sites. Sometimes we cannot, but it all depends on, where, this patient has metastasis. There's a lot of a discussion about, for example, doing surgery to remove the primary tumor in a patient with metastasis, which is something that we know that usually we don't do because we're not going to increase, life expectancy for this patient. But sometimes we have to do it. For example, if this patient has any kind of a bleeding or obstruction or something like that. So it's a very complex, scenario. So and that's why we have to, individualize this.
Yeah, I loved your image in your slides about precision medicine and how, in the past, it may have been kind of easier to answer a lot of these questions because it was kind of one treatment for all. But as things have evolved, the advantage is that we're actually able to deliver the best treatment for your needs, your social needs, your life needs, but also the specific tumor you have, your specific characteristics, and that makes it critical that you see somebody that you really has all this knowledge and incorporate all of this. AI definitely will have an impact into that. Okay, I'm going to go into the last question because we're kind of getting close to our time. So, be sure that we will be, for those of you that we didn't answer all the questions, we will be kind of responding and sending the questions after the fact, regardless. But this last question is, with the stage 4 colon cancer, KRAS, NRAS wild type, is immunotherapy effective? Dr. Pilon-Thomas, do you want to tell us a little bit about how mutations and specific mutations can influence the role of immunotherapy?
So I think the question was about wild type KRAS.
Correct.
So, our immune system really targets mutations, right? This is how it recognizes something that's not self, that it likes to recognize. And now in a patient, and Dr. Biachi, you can correct me if I'm wrong, that does not have those KRAS, NRAS driver mutations, they probably have other mutations that are specific to the patient which we call neoantigens, which can be targeted by the immune system and therefore by immunotherapies. But
yeah, it all depends on what kind of immunotherapy we're talking about. If we're talking about, for example, those drugs like pembrolizumab, nivolumab, etc., for a patient with metastatic disease, the group of patients who really benefit from those drugs is very small, actually, or essentially those patients with the MSI high or mismatch repair deficient tumor, which is about 3, 4, 5% of patients. Having a tumor that is RAS wild type, BRAF wild type, this means essentially that this, for example, this tumor is sensitive to a class of drug they call anti-EGFR, like panitumumab or cetuximab. Those are not immunotherapy; they are targeted therapies targeting a receptor that we call EGFR, which is located in the surface of the cell.
Very good. Okay, well, I think we've run out of time. That will do it. But thank you all. We really want to thank you for your engagement. Great questions, really up to date on everything. And thank you again for being with us tonight. And we hope that you found this webinar informative. We certainly appreciate your continued support as we continue to work to really change cancer care and provide the best possible outcomes and results to our patients. Thank you so much and have a great night.